Sure. Good morning, everyone. Our dear participants out there, I hope you can hear me clearly. This is Rhoda Wanyenze, professor from MNCAAH School of Public Health. I'll be chairing this session. We have had some challenges with the technology, but we are planning to start in under 5 minutes. Kindly bear with us as we prepare to start. We're trying to get some of the panelists that are not yet logged in due to the technology challenges. We'll be with you shortly. Emily, should we start?
Perhaps.
Yes, as we try to get to Dr. Fowle and Abera. So we are going to start with, we are going to make some shifts in the program. So good morning once again. Our participants, we are delighted to welcome you to our session on the impact of COVID-19 on access to essential healthcare services. Once again, my name is Rhoda Wanyenze. I'm a professor and the Dean, School of Public Health at MNCAAH. I'll be co-chairing this session with Professor Fowle from the University of Ibadan. She'll be joining us a little later into the session. So this session comes at a time when several countries in Africa are experiencing an upsurge of COVID-19, some of them getting into the second wave, while others are getting into the third wave, and one country getting into the fourth wave. So it comes at a time when we are anxious to control COVID, but also to make sure that as we do so, we do not compromise access to essential services, other essential services beyond COVID. So the purpose of this session is for us to raise awareness on this issue of the need for us to maintain access to other essential health services, to identify and share the challenges as well as solutions across countries in Africa. What have countries done to reduce the disruption of COVID and the interventions related to COVID on access to services? We hope that this can put to the forefront the dialogue at national level across various countries and at the global level in terms of the need to maintain other essential health services, and also the strategies that can be used to minimize disruptions to these services. This session is co-hosted by MNCAAH University School of Public Health and the Exemplars in Global Health. The Exemplars in Global Health program is a joint endeavor of Gates Ventures and the Bill and Melinda Gates Foundation that aims to support the adaptation of successful global health solutions in new contexts by conducting research and analysis to improve funding and policy decisions. We study exemplar countries, as we call them. These are countries that have been able to outperform others within relatively similar contexts. And the purpose is to understand which factors drove their success. And then we work with global decision makers to adapt these lessons to their own contexts. And today we will hear from 2 research partners of the exemplars from MNCAAH University School of Public Health, as well as the University of Global Health Equity. But we are also privileged to have the World Health Organization team from the regional office, as well as the World Bank Global Financing Facility that have also been conducting a tracking of how countries are performing in this area. And they'll be sharing with us these experiences across various countries in Africa. As we go along, if you have any questions for the speakers, we kindly request that you put them in the chat, the Q&A function. We will be picking up these questions as we go along. And at the end of the session, we will have an opportunity to discuss these questions that you have sent. And if time allows, perhaps some more questions that will emerge during this discussion time. So we are now moving on to start the presentation, and we are going to start with Mr. Stephen Kawama, who will share with us his presentation on emerging findings from exemplars in COVID-19 response, a cross-country synthesis and recommendations on maintenance of essential health services. Mr. Kawama is an epidemiologist with a bachelor's in food science and technology from MNCAAH University and a master's in public health from University of Southern Denmark. He was also a field epidemiology fellow and focused his work on non-communicable disease epidemiology as well as disease outbreak investigations. He currently works with the School of Public Health at MNCAAH University as a training manager on the field epidemiology training program. He's the current lead for the assessment of the country efforts to maintain services during COVID in Uganda, Nigeria, Senegal, and Democratic Republic of Congo. Mr. Kawama, we are looking forward to your presentation. The floor is now yours for the next 15 minutes. Welcome.
Thank you, Prof. Roda, for those introductions. Could we go to the presentation? Yes. So like I've been introduced, I work at MNCAAH University School of Public Health, and I'm going to present the work that we're doing with exemplars in global health to document exemplar countries in the COVID-19 response. And this presentation will focus on the maintenance of essential health services. Next slide. So this is going to be the project overview. Like Prof. Roda mentioned, when public health emergencies occur, they cause disruption of other routine service delivery, and response interventions such as the curfew and movement restrictions also affect health access. From our findings, the high-level recommendations include for countries to develop clear guidance and disseminating it in order to maintain services. And then the development of innovative service delivery strategies, which we'll go into in this presentation. The importance of utilizing data to inform interventions, and the importance of oversight, coordination, and partnerships to ensure that services are maintained. And next slide. So for this work, we use the two-pronged approach, starting with short-term research sprints to inform current practice, and which will feed into longer-term research about countries exemplary in responding to the pandemic. So by exemplar response, we mean countries that have outperformed others in response and control of COVID-19 while maintaining services. So looking at the policies used, the specific actions and interventions, and how these are adjusted as the pandemic progresses. So there are 4 research sprints that are being conducted. Today we'll focus on the one on maintenance of essential health services. Next slide. So this slide shows the analytical framework that guided our thinking as we did this work. So we considered that public health emergencies occur within health system contexts, and baseline interventions in these systems determine the extent of services disruption. Response interventions, response involves institution of population level public health and social measures, such as mask wearing, movement restrictions, and these work together with health system interventions, such as, for example, the designation of facilities, integration of service delivery models, and how effectively these perform lead to the maintenance of essential services in terms of utilizing the services, but also the quality of these services being maintained. Next slide. This is just a brief description of the approach. We analyze data on specific service utilization indicators from March to December 2020, and we compared this with the previous 2 years, 2019 and 2018, and then conducted desk research, and then looking at government policy documents, guidelines, any published information, and then supplemented this with key informant interviews. Thereafter, we synthesized the findings across the 4 countries. Next slide. So I'm now going to go over the synthesis of findings from the 4 countries for the African region. So the 4 countries varied in context, with Senegal and Uganda being comparatively smaller in population size. They also had better life expectancy compared to DRC and Nigeria. Senegal and Uganda also had better DPT3 coverage as a proxy indicator for baseline strength of the health system. Nigeria spent more in terms of health expenditure per capita, while Uganda spent less. Related to COVID-19, Nigeria was the first to report a COVID-19 case on 27th February 2020, while Uganda recorded it last on 21st March 2020. So the countries varied in terms of background context. Next slide. This slide goes over the public health and social measures implemented by countries to combat the spread of COVID-19. And I won't go into each of them in detail, but generally they included mobility restrictions such as curfew, land and air traffic closures, measures in public places such as the compulsory mask wearing, school closures across the 4 countries, and then support to vulnerable populations. We saw in Senegal, for example, the paid utility fees, and then provision of relief food in Uganda. So there was a variety of public health and social measures implemented across the 4 countries. Next slide. These graphs show the disruption of DPT3 as a proxy indicator for services disruption. You notice that there's a variation where you see in DRC there was minimal disruption. For Nigeria, there was significant disruption in March, followed by recovery by August. For Senegal, there was significant disruption, but it took time to recover, while for Uganda, there was significant disruption in March, but there was full recovery by May. So again, the countries varied in terms of service disruption. Next slide. This slide shows the way countries leverage technology to minimize the need for patients having to return to health facilities for specific services. And these include use of virtual platforms to monitor program implementation in DRC, conducting follow-up using phone calls in Nigeria, Senegal, and Uganda. In Senegal, there was also use of video observation to monitor adherence to treatment, use of social media to promote health access, and use of digital solutions for ordering commodities for both COVID-19 but other essential health commodities in Uganda. Next slide. So the countries also redistributed tasks among health workers to ensure service delivery was maintained. Across the 4 countries, they leveraged community health workers, provide services such as ANC, treatment of diarrheal diseases, and promoting the continuity of access to services through conducting referrals. In DRC, they also leveraged nurses and midwives in training to support the response. For Senegal, they also formed community vigilance awareness committees that conducted surveillance, but also promoted access to services. Community actors and religious leaders also promoted access to maternal and child health services in Senegal. For Uganda, they used non-medical staff such as security guards to conduct tasks such as temperature screening in health facilities so that other health workers wouldn't have to do these particular tasks. Next slide. Countries also engaged in innovative service delivery strategies to maintain services, including dispensing drugs for multiple months, which were conducted in DRC, Senegal, in DRC, Nigeria, and Uganda, self-initiation of care, mobile surgery clinics that were done in DRC. For Senegal, they provided hotlines for people to call in order to reduce home deliveries, and then patient follow-ups using telephones. For Uganda, health workers readjusted schedules to allow services continuity, and then designation of facilities for COVID-19 treatment, which is a case study I'll go into later in the deep dive. Next slide. So the next couple of slides are going to go over some specific findings for Uganda. Next slide. So this graph shows the trends in health access for Uganda using facility data. And what you will notice is that there was a drop in health services utilization around the end of Q1 in April in 2020 compared to 2019 and 2018 for both DPT3 and health facility deliveries. For malaria, there doesn't appear that the burden increased last year, but for maternal deliveries, there appears to be a significant disruption in terms of increase in the number of maternal deaths. So again, the services disruption varied across indicators and health programs. Next slide. So over the next two slides, I'm going to go through the challenges and innovations that were implemented in Uganda using the building blocks of the health system. Starting with governance, we noted a challenge of inter-pillar coordination where the same people had to attend multiple response committee meetings, and then the focus on maternal and child health and HIV/TB services, neglecting other disease programs. The innovations included Uganda established a multi-sectoral coordination committee that oversaw the efforts to maintain services. So looking at the interventions and then following up on these interventions even across districts. And then there was also media campaigns that were conducted to promote continuity of access to health services. For health workforce, the challenges were the movement restrictions that affected health workers, closure of facilities due to infection of health workers. We saw what happened in Kapchora, fear of contracting COVID-19 among health workers, and then the inadequate human resources where some health workers that did the routine service delivery were repurposed for the response. The innovations included the development of guidelines and SOPs for health workers, recruitment of volunteers, use of non-medical staff, like I mentioned earlier, provision of psychosocial support, and then leveraging the community structures using community health workers. Related to finances, there was a delay in disbursement of funds, particularly related to the other implementing partners, and then inadequate resources that were dedicated to ensuring services were maintained. The innovations were mobilization of resources, so government and donors, and then of course government continued providing funds quarterly to health facilities to continue providing services. Next slide. So the challenges for a health service delivery were the repurposing of facility space to make isolation units, the movement restrictions that affected patients, suspension of outreach programs. Interventions included designation of facilities for COVID-19, which allowed health access elsewhere to continue, And then new service delivery strategies such as multi-dispensing, enhancement of triage, and integration of services. For example, gender-based violence into ANC services. Related to infrastructure and commodities, there was stock out of commodities such as PPE, testing reagents, some family planning commodities, and then the innovations were engagement with the private sector, procurement of IPC commodities by government and donors, and then use of e-platforms for ordering commodities. Related to health.
Pardon? 3 minutes.
Yes, please. For health information systems, there was a decline in reporting, postponement of surveys, and the interventions included provision of tools that were lacking. Next slide. This slide just a case study on the designation of facilities for COVID-19. So at the beginning of the pandemic, the national referral and the inter-regional referral handled COVID-19 patients, but as the cases grew in number, the regional referrals were equipped to also handle COVID-19. The advantages of this was that it delayed the spike in cases at lower levels of the system, and then allowed for optimal use of resources at regional referrals while maintaining services. The challenges, of course, were the fear of infection in the regional referrals, and some services offered in the regional referrals being neglected, such as mental health. Next slide. So as I wrap up, this slide shows the recommendations to other countries based on learnings from Uganda and those to Uganda. For the learnings from Uganda, they include the establishment of the multi-sectoral committee to oversee and monitor efforts to maintain services, and then the implementation of service delivery strategies such as multi-month dispensing, community distribution of drugs, and leveraging other workers in health settings to conduct tasks like temperature screening. The lessons from other geographies applicable to Uganda include the importance of effective risk communication messages, improving the health workforce surge capacity, and the importance of ensuring a comprehensive approach to all services to avoid neglecting some services such as mental health. Next slide. Yeah, I'd just like to end by acknowledging the project secretariat at Makerere University School of Public Health, our research partners in Nigeria, Senegal, and DRC, as well as our partners, Gates Ventures, and our funders, Bill and Melinda Gates Foundation. Thank you. Over to you, Dr.
Thank you very much, Stephen Kawama, for sharing those lessons in maintenance of essential health services in Uganda, DRC, Nigeria, and Senegal. We are now moving on to the next panelists from the World Health Organization, Dr. Teshome Desta and Dr. Abera Alemo. This was supposed to be our first presentation, but we are now taking it as the second for those who have just joined us. And please do post your questions in the chat if you would like to answer any questions or clarifications. Dr. Teshome is a medical doctor and a specialist in pediatrics and child health with over 35 years in medical and public health practice. He previously also worked in academia and was an associate professor, and is currently the regional advisor for child and adolescent health in Eastern and Southern Africa under the WHO regional office in Africa. And the other panelist for this presentation is Dr. Abera Alemo, who is also a medical doctor and has also extensive experience in public health in Ethiopia, as well as other countries in sub-Saharan Africa. And he's currently a regional advisor and consultant to the World Health Organization office, AFRO, for sub-Saharan Africa. And he is supporting the efforts to assess the impact of COVID-19 on continuity of essential health services, including maternal, newborn, child, adolescent, and the aging health services across 5 countries, including Cameroon, DR Congo, Ethiopia, Nigeria, and Uganda. Welcome, Dr. Teshome and Dr. Alemu. The floor is now yours for the next 15 minutes. Thank you.
Thank you very much, Prof, for this opportunity. Can you see my screen?
Yes, we can see your screen.
Yeah, okay, thank you very much. Steve has already presented for the 3 of our 6 countries. So I'll not spend much on that because most of the issues are the same. So the outline of our presentation is as follows: a brief introduction, and then we will share some key highlights from the WHO Health Survey in January-March this year. We also share some key highlights and lessons from the WHO initiative on the mitigation of COVID-19 on MNCAAH services in the 6 countries that Prof has mentioned, and we'll also share some key lessons and some challenges and concerns, and finally a way forward. So the objective of monitoring of continuity of essential services is really to detect and estimate the level of disruption of essential services as soon as possible in order to trigger corrective actions, and also to ensure access and utilization of quality essential health services in order to prevent increase in mortality, morbidity, fertility, mental and physical ill health, and contribute towards the achievement of the SDG goals. So what are some of the factors affecting access to essential health services during the COVID-19 pandemic? We have supply side factors as well as demand side factors that will influence the coverage of essential health services during the COVID pandemic. Some of the supply side factors has been mentioned by the previous speaker. I don't need to dwell a lot on that, but basically some of them are like designation of facilities for COVID care or closure of facilities, and resource shortage, especially redeployment of human resource, and budget diversion, as well as a shortage of PPEs. From the demand side, it has been already highlighted in the 4 countries: lockdown measures, movement restrictions, fear, stigma, misinformation, and also community concerns about quality and safety of services. So these are some of the factors. So WHO has conducted a second pulse survey. The first survey was conducted for the May to July, and the second survey was covering January to March this year. In this pulse survey, 135 countries and territories participated in the pulse survey on continuity of essential services during the COVID pandemic. And 40 of these countries are from the African region. And the findings offer insights from country key informants into the extent of the impact of the COVID pandemic on essential health services across the life course, and also the reasons for those disruptions, as well as the strategies and approaches taken by countries to maintain service delivery during this pandemic. The findings of the 2 rounds of this survey highlights the need to improve real-time monitoring of change in service delivery and utilization beyond pulse surveys. The full report links are attached with this presentation. Here you will see the average level of disruption across 63 tracer services in 40 countries in the African region. So in summary, you can see 95% of the 40 countries reported one or more disruptions to essential health services, with an average of 42% of service disruption, at least partially, in each country. 8% of the services were disrupted by more than 50%. So severe disruption was not that common. I think this is a point we need to note. Only 8% of the services were disrupted by more than 50%. Another 8% of services were disrupted between 26 to 50%, and 26% of the services were disrupted between 5 to 25%. As you can see, the green bars stands for service disruption between 5 and 25%. So 7 of the 40 countries have green bars. And you can see countries with longer red bar have countries that have more than 50% of disruption of essential services. And this slide shows you the level of disruption for 8 tracer services. So you can see most of them are in green, meaning the disruption was between 5 to 25%. And the red indicates more than 50% disruption, but fortunately, they are not that common. This slide shows you the reasons for service disruption. As you can see, the most frequent reasons are insufficient staff availability for various reasons, either redeployment or fear, and followed by community fear or mistrust in seeking care, financial difficulties during the outbreak, and as well as insufficient personal protective equipment, travel restrictions, unavailability stockout of essential medicines. So fortunately, closure of outpatient services or closure of outpatient clinics were noted only in 6% of the countries. So closure was not really a common reason for the disruption of the essential health services during this pandemic. So what are some of the strategies or measures that countries have taken to overcome the challenges and in order to maintain continuity of these essential services? Community communication was one of the commonest measures taken by most countries because community mistrust, fear, and so on was common. Recruitment of additional staff, triaging to identify priority cases, redirection of patients to alternate sites, provision of home-based care where appropriate, self-care interventions, task shifting, and innovative approach in dispensing approach for medicines, especially chronic care and so on, integration of several services into a single visit, and also changes in prescription approach. Some countries were authorizing community health workers to prescribe some medicines like iron folate and so on. So government removal of user fees was noted in about 8%, expanding facility working hours in about 11%. So these are some of the strategies taken by countries to overcome the disruptions. So now we're coming to the WHO initiative on mitigation of the COVID-19 on MNCAAH services. Basically, this is a kind of framework to collect information and analyze and synthesize that would be used for decision-making for response to mitigate the indirect effect of COVID. So WHO has supported the 6 countries, Cameroon, DRC, Ethiopia, Nigeria, Uganda, and South Africa, where we have 1 or 2 national consultants to give an extra pair of hands to the WHO staff, where most of them have been repurposed to COVID response. to support the government efforts to respond to COVID and maintain continuity of essential services by working closely with the technical working group in order to adapt effective strategies, guidelines, and SOPs. This was really implemented within the health system context, focusing on governance issues to make sure they have a national plan for continuity of essential services, representing in the technical working group, working with the incident management team, mobilizing partners, and also on the guidance, like I said, developing guidance, SOPs, and also in the area of information, monitoring key RMNSH indicators on monthly basis, producing dashboard, and giving feedback to the Ministry of Health for decision making, and also actions to mitigate the impact. So the overall effort was really to make the response effective in maintaining RMNSH services. So we have monitored a set of core RMNSH indicators on monthly basis. Some countries have selected 20, 18, less than 30 anyway. So these are some examples to show you how the trends of these indicators are in terms of recovery. In summary, the core RMNSH indicators have shown different trends of recovery in different country contexts. But looking at the SRH family planning, we have observed variable trends in service delivery across countries. And if you take Ethiopia, the number of women receiving comprehensive abortion care services decreased throughout 2020 after the onset of the COVID pandemic. You can see still much lower than the 2019 trend. We have also noted increase in number of gender-based violence in 2 of the 6 countries, in Uganda and DRC, as you can see. We have also noted increase in contraceptive distribution and use in all countries except for initial drop in South Africa and Uganda, which quickly picked up after about September or so. Coming to maternal newborn health, we have also observed fluctuations in delivery of several MNCAAH services in 2020 compared to the previous year, 2019. The numbers of ANC, PNC contacts for mothers and newborn care varied across countries. Facility births reported from little to no change in some countries, or increase or decrease in others. So if you see the trend in DRC, it is performing much better this time around than the previous year. But we have a lot of reasons behind this observation. In child health and immunization, also we have variable trends in childhood prevention and treatment services. But immunization or vaccination was one of the services that has been affected in many countries, even beyond these 6 countries. So there was a drop in vaccination coverage in DPT3, Penta3 antigen, and children seeking care for diarrhea, ARI, malaria declined throughout 2020 in most of these countries. In the second WHO Pulse survey, we have collected very important information around digital health to see the percentage of countries reporting use of health technologies to support service delivery. You can see it has been used in many ways to provide service for consultation, for scheduling, and so on. And we have also collected information on percentage of countries reporting barriers to use of health technologies, starting from limited access to health technology to limited organizational and technical capacity, infrastructure capacity, and so on. We have also noted that the high-income countries have used digital health technology most, almost 96%, close to 100%. So in summary, we have noted that during this pandemic, there has been a substantial upsurge in digital health interventions to maintain communication with different levels, with health workforce, service users, and other activities such as capacity building and teleconsultation.
Dr. Teshome, may I request you to wrap up in 2 minutes?
Yes, I'm almost there.
Thank you.
Some of the key lessons is really the need for a coordinated emergency response involving the incident management team, the health system departments, and the life course and disease-specific programs, as well as implementing partners, is really critical for a unified response. Achieving a balance of measures to mitigate COVID-19 infection with actions to maintain the delivery and use of essential services would require a specific plan for maintaining MNCAAH essential services as part of the country integrated plan for emergency preparedness and response. I think it's important to note that this response cannot be handled by the health sector alone. So it really takes a whole of government approach in order to ensure effective response. The central importance of support for health workforce, including their physical protection, as well as their mental health needs, capacity to assume new tasks, was stated by most countries without undermining the importance of financial motivation. The role of the private sector is really important to emphasize here in many ways. And some of the challenges and concerns are really in the area of new waves of COVID coming, virus variants, and vaccination. This has been major issues of concern. And with regard to the COVID-19 campaign, we have seen redeployment of health workforce, diversion of medicine supplies, resources, and finances as issues of concern. Data is really a powerful tool for monitoring services, but data quality analysis and visualization and use for decision-making continue to be a challenge. I think some of these are more of, I think one thing that I want to emphasize is we should not be deceived by the apparent recovery or return of services to baseline of 2019 or previous year, since this may mask a different trajectory for some vulnerable and most at-risk individuals and communities, whereby prolonged disruptions may go undetected and result in severe health impacts, basically due to limited administrative data on the health of some population groups or less attention to these groups. So finally, I would like to highlight some points as a way of forward. It is really critical to strengthen coordination and collaboration with relevant programs, stakeholders, including the incident management teams. And it's important to continue monitoring of continuity of essential services, using real-time data to inform policy decision and programming. And it is also critical to strengthen advocacy for data sharing by member states to inform public health emergency response, ensure continuity of essential services. And it is also important to integrate MNCAAH actions into the country preparedness plan for future events, emergencies. And finally, we need to continue and support documentation and dissemination of best practices so that we'll be better prepared for future similar events or emergencies. So these are some of the people who have contributed to this presentation. And thank you very much. Asante sana, Sukomo, Amasegnalo, Merci, Tatenda, Nagode. Thank you very much. Over to you, Prof.
Thank you very much, Dr. Teshome, for sharing those experiences from the WHO work across countries in Africa. I will now hand over to Professor Fowler, who has finally been able to join this session as co-chair to introduce our next speaker from Rwanda and from the World Bank team. Welcome, Professor Fowler, to take us through those two sessions.
Okay. Good morning, everybody. I hope you can hear me. Good morning, everyone.
We can hear you, Professor Fowler.
So thank you very much, my co-chair, Dr. Wanyeze, for holding forth while there were minor issues. Now we move on to the next presentation. Of course, thanking Mr. Dr. Voldehana for his beautiful presentation, where he was sharing the work of WHO Afro on maternal, newborn, and child and adolescent health as regards essential services during the COVID-19. The next presenter is Dr. Ale Mayehu, who is also speaking on the essential services. His presentation is titled Maintaining Evidence-Based Interventions for Maternal and Child Health Services During the COVID-19 Outbreak in Rwanda. He's telling us or presenting to us an implementation science approach. So Dr. Alemayu is a very well-known scholar, and he is a medical epidemiologist of over 13 years of work experience, and he has worked both in the academia and on field research. His countries of exposure include Ethiopia and Malawi. Dr. Alemayu was most recently the Implementation Science Director at the University of California, Los Angeles, and he was based at the Partners in Hope in Malawi. He is currently working as a doctoral scientist at the University of Global Health and Equity based in Kigali, Rwanda. Please, Dr. Alemayu Ambabri, the floor is yours. Over to you. Thank you.
Thank you so much, Professor Fami, for that kind introduction. Can you see my screen?
Yes, I can. Please go ahead. You're on the floor.
Thank you so much. Title of the presentation is Maintaining Evidence-Based Intervention for Maternal and Child Health Service during COVID-19 in Rwanda, which is an implementation science approach. These are the outlines of the presentation: COVID-19 in Rwanda, implementation research in exemplars for under 5 mortality, brief description of the methods, some findings, and we'll end the presentation by concluding. So, as the previous speaker indicated from the WHO second round pulse survey, nearly 94% of the 135 countries and territories that participated in the study reported a disruption in essential health services, and most of the services include reproductive, maternal, newborn, child health, and adolescent health, and nutrition. And coming to the COVID-19 in Rwanda, until recently, we have just over 6,000 confirmed cases and around 420 deaths reported so far. And in terms of the response to the COVID-19 in Rwanda, Rwanda showed an exemplary response to COVID that include rapid enforcement of non-COVID-19 evidence-based interventions, including border closing, lockdowns, etc., and infection and prevention and control practices. Equitable approach to the COVID-19 response, particularly welfare support and free testing, contact tracing, isolation, and quarantine, and adoption of various technologies. Our study objective is to look at if and how evidence-based interventions known to reduce under 5 mortality were maintained during the period of COVID-19. We looked at implementation strategies used to prevent or respond to these evidence-based interventions. These evidence-based interventions for under 5 mortality include the vaccination, facility delivery, neonatal care, etc. What contextual factors helped or hindered the success? Where did we see evidence of health system resiliency? So coming to the methods, we conducted an implementation research just to highlight that implementation research is basically research that fills the gap between the evidence-based intervention to a significant health problem. So there is a research that provides evidence, and there is a practice or implementation research evaluating strategies that help us to integrate evidence-based intervention into a real-life setting. So our overall approach, we build on under 5 mortality exemplar work that highlighted by the first speaker. Basically, we used a hybrid implementation research framework adopted from the previous work that looked at how and why Rwanda outperformed in the reduction of under 5 mortality between the period of 2000 to 2015, looking at a number of implementation strategies and a number of contextual factors at a different level from a global Ministry of Health to national level. So we adopted those implementation frameworks. And we also utilized the health system resiliency framework from Crook and colleagues that encompasses 5 key domains from adoption, self-regulating, diverse, aware to integration. Coming to our approach, the first approach we used was desk review, looking at the permit medline searches, multiple country case report, and in-country guideline and reports. Other data sources include the key informant interviews. We conducted 21 key informant interviews, including the study. These key informants were selected from various stakeholders within the health system, ranging from MOH, Ministry of Health to a private sector. And then we utilized HMI's data for quantitative analysis that ranges the time period between January 2017 to February 2020 as before COVID and March 2020 to December 2020 during COVID period. For the quantitative analysis, we utilized uninterrupted time series analysis, as I mentioned earlier, prior COVID from January 2017 to February 2020, and then during COVID, March 2020 to December 2020, and we utilized a Poisson regression to estimate the impact of COVID. And for qualitative analysis, interviews were transcribed and we used standard qualitative software. Coming to the results, first to our quantitative findings from analysis of the HMI's data, looking at this scatter plot for the vaccination, the TP3, HPV, and the HIP3, the pentavalent vaccine, and the rotavirus vaccine. Looks like vaccination coverage maintained well before and after, before and during the period of COVID. Then if you look at the scatter plot, there is clearly, this is across the 30 districts in Rwanda. There is some level of subnational variability, whereas the mean predicted for Rwanda remains well maintained. Looking at, it looks like there is a slight increase in antenatal care coverage attendance, whereas the fast delivery maintained well, but clearly there is again some level of subnational variability across the 30 districts. There is a drop in diarrheal cases treated both at the facility and at the community level during the period of COVID. So clearly there was a reduction in OPD attendance as well as community health attendance for both for diarrheal disease as well as for pneumonia, a drop in pneumonia cases treated both at the facility and community during this period. Coming to the key informants findings, the change in essential health services. This is a report from the key informant at a various levels. So that shows you some sort of variability by facility, by a district. For example, in some facility, some key informants reported some sort of a slight drop in coverage of vaccination, a decrease in OPD consultation, some sort of change in antenatal care coverage, facility-based delivery, and interruption of gross monitoring. But generally, recovery of service was quick, and service bounced back after the first few months, usually March, April last year, and there was strong community sensitization, collaboration across partners. So key takeaways include some of the cause of the reduction according to the key informants include challenges of transportation, community and healthcare workers fear shortage of healthcare workers, particularly in the early phases of the pandemic. And there was also some sort of change of a disease pattern, including a reduction in infectious disease due to school closures, lack of mass gathering, wash intervention, etc. So what are the implementation strategies that help to prevent or respond to this evidence-based intervention drop, for example, antenatal care or fast delivery or vaccination? This include, there are a number of implementation strategies. Some of the most important one include community-based healthcare delivery, data utilization of data use for decision-making, the mentorship and supervision, a provision of transport, community engagement, the use of digital platform, particularly using WhatsApp group for monitoring and evaluation indicators, using WhatsApp group for professional associations, professional members, to make a clinical decision. A policy is another implementation strategy. For example, ensuring that essential health services are shouldn't be disrupted. Donor and implementing partner coordination is another key strategy. The focus on equity, particularly redirection of funding to support the vulnerable group, or provision of welfare support, for example, nutrition support, etc. And then leveraging existing system is also one of the key strategy. For example, leveraging the previous Ebola epidemic preparedness, and then utilizing that, learning that lesson into a COVID response, and then the development of the command post or some sort of an emergency response team from the national level to lower level are also one of the key implementation strategies. So just to highlight some of these, for example, for the response to COVID-19 that supports to maintain the evidence-based intervention, community health workers and health facilities were provided with PPs, additional vaccination days, for example, that helped maintain some of the EPIs, a toll-free number, and other COVID-19 preventive measures that support to maintain the essential health service. The community-based healthcare delivery, utilizing community health workers to identify children who missed vaccination, education, and a focus on primary health care, as well as visiting the schools by the community health workers. Data use is another important implementation strategy that helped prevent the drop. Review of data at the lower level of care. Partners use the same HMIS data platform and analyze, make a decision at coordination. And the use of electronic register was also another data use. Mentorship and supervision is another one, a technical mentorship group, particularly by clinician moving around the districts due to problems with the referral for neonatal care. Supervision of community health worker via telephone, and then limiting number of supervisors per vehicle, but still continuing supervision. So bringing this into context, what are the facilitating contextual factors that help the implementation of these strategies? Those include the collaboration, coordination between particular donors and implementing partner, community health worker, the existence of the community health worker system, the system of learning and improvement, the data availability, supply chain system, the leadership and control, and the culture of accountability. So highlighting some of these facilitating contextual factors, for example, for collaboration and coordination, existence structure of collaboration through the national strategic plan that prevents duplication of effort in this during this pandemic. The existence of this community health worker system, a strong facilitator at community level. The system of learning and improvement, particularly regular monitoring and evaluation of supported identification of disrupted health services, data availability of data through HMI, centralized data reporting system, and the supply chain system, strong supply chain prevented stock out, for example. What are the challenging contextual factors? So despite those important facilitating contextual factors, there are a number of challenging contextual factors as well, particularly I think the one related to lockdown movement restriction that prohibited transportation. And a stock out generally is not a big problem in Rwanda, but there was some issues in some facilities, in some districts due to the disruption of movement. Community fear of COVID-19 was particularly an issue at the early beginning. And then workload staff shortage was also some sort of an issue at the beginning, and healthcare workers' fear of COVID-19 was also one of the challenging contextual factors. So where do we see health system resiliency in the Rwandan health system, putting these the previous implementation strategies and contextual factors into context? So clearly there was some adaptability of the health system, strong motivation to adapt strategies. There was task shifting happening, there was budgetary allocation happening, and there was also awareness of disruption of the essential health service through regular evaluation of data and local decision making. Continued maintaining of core function, prioritizing essential health service and critical follow-up of patients with other conditions, and maintaining straight line of communication and referral between different levels of system. And all service delivery activities continue with support of leadership despite the threat of the pandemic. What lessons have been learned? So some of the transferable lessons identified from our key informants include that helped for the Rwandan health system to respond or mitigate the drop in the evidence-based intervention for under 5 mortality, include investing in health system and then leadership at all levels, coordination of activities, particularly between donors and implementing partners, data use for decision-making at all levels, ownership, timely information, public trust, and then innovation and the focus on equity. In conclusion, Rwanda maintained most of the evidence-based intervention for the reduction of under 5 mortality during the period of COVID-19. Example, vaccination first delivery. Service bounced back after the first few months, particularly during the March and April last year. Lockdown and movement restriction and fear of COVID by the community as well as healthcare workers were barriers to service delivery, particularly in the early period of the epidemic. Key implementation strategies used to prevent or respond to the evidence-based intervention include community health, the extent of the community-based healthcare delivery, data use for decision-making, mentorship and supervision, provision of transport, community engagement or education, and the use of digital platform. The ability of the Rwandan health system to adapt encourages flexible response to fit situation, but we call it health system resiliency. And then some of these transferable lessons include investing in health systems, leadership, coordination of activities, data use for decision-making, ownership and accountability, and the timely communication and public trust. So these are my acknowledgements presented on behalf of my team and the Rwandan MOH in country partner, the Gates Venture and the Bill and Melinda Gates Foundation for funding this study. And then of course, our key informants who generously provided their time and insights. Over to you, Professor. Thank you very much.
Okay, thank you very much, Dr. Amber Brough, for this enriching perspective on maintaining essential evidence-based intervention for maternal and child health during the period of the COVID-19 in Rwanda, an implementation science approach. It was very enlightening. Our next panelists are Dr. Tashkil Ahmed and Jean Rusatira from the World Bank Global Health Financing Facility. Dr. Rusatira is a result-based financing consultant at the Global Financing Facility Secretariat in the World Bank. He is responsible for providing technical and operational support to design, monitor, and implement result-based financing in countries with GFI portfolio. Jean's experience working in low-income and fragile settings include Rwanda, Congo-Brazzaville, Laos, Cameroon, Guinea, Chad, and Yemen. Most recently, Jean is contributing in rapid monitoring of essential health services in GFF partner countries to estimate disruptions in delivery of routine health services due to the COVID-19 pandemic. Dr. Ahmed is a consultant with the Global Financing Facility for Women, Children, and Adolescents. Since 2000 May, Dr. Ahmed had led a team in conjunction with the World Bank Development Research Group, DC, in conducting rapid monitoring of essential health services in GFF partner countries to estimate the disruptions in the delivery of routine health services due to the COVID-19 pandemic. Dr. Ahmed previously managed the infectious disease modeling and COVID-19 analytics for the Washington, DC Health Department to inform strategic response and vaccination rollout. He was previously a faculty member at Johns Hopkins University, country director for a CDC program in Liberia to support the redesign of the disease surveillance program following the 2013 to 2016 Ebola epidemic. Dr. Ahmed and Rusatira, we are looking forward to your presentation on monitoring essential health services during the COVID-19 pandemic. The floor is yours.
Yeah, thank you, Dr. Fawale. Can you hear me?
Yes, I can. Please go ahead. The floor is yours.
Yeah, thank you. So we are pleased to present our work on the monitoring of essential health services during the COVID-19 pandemic. So I will quickly talk about some objective, and then I will leave the floor to my colleague, Dr. Tashrik, who's gonna talk more about the methodology and finding. Next, please. So the objective of GFF activity in supported to our country portfolio. So we really focus on rapidly identifying and quantifying service disruption due to the pandemic using this data software to inform health services intervention, and also to create a body of knowledge to inform preparedness effort for future crises. We also intend to place some particular emphasis to the need for capacity building and sustainability within countries. So because we have seen that this has the value of this monitoring exercise as an ongoing tool that should be integrated into a routine health surveillance exercise. Next, please. So these slides summarize the overall support to country in this work, but today we are really presenting the HMIS activity assessment as a part of the large portfolio. So in panel A, we can see that our support that we provide to country to monitor the HMIS services volume for key services. In panel B, we discuss the implementation of rapid facility assessments through phone survey, which give us more context on HMI services disruption and allow also some qualitative feedback from the field. In panel C, you can see that we also triangulate with supplementary data, particularly through a country dialogue platform. And also, there are also some other household surveys that are conducted by the World Bank on demand side in the effort of having more complementary information. And then finally, in panel D, it's about our overall contribution to the global knowledge by developing a multi-country analysis. Next, please. So this slide just summarizes the support to some countries. So we have active HMIS monitoring exercise in 21 countries, but also ongoing or upcoming rapid facility survey in 10 countries. I'll quickly give the floor to my colleague, Dr. Tashik, for the following slide. To you, Tashik. Tashik, we can't hear you. Are you there?
Or do you continue the presentation if he's not there? Would you continue?
I think it's
wait a few
so
minutes.
this. Okay, sure. So this really it's the methodology on quantifying the disruption. So we first identify data from the HMIS, mainly the DHS2 from countries, and then there is a data processing, and then we also develop a counterfactual that would to show that the volume of service that have been how the service could have been without the pandemic, and then we have some consultation with the countries to discuss the primarily the draft findings, and then also we triangulate with other sources, as I said previously. Next. So here we have analysis on facility data quality adjustment, and we first analyze the data completeness. Also, we identify outliers to I have some returns from my.
It looks like we have Dr. Rusatira back.
Jean, are you able to hear me now?
Oh,
Yes,
yes, hearing you though.
Apologies, I had some technical issues. I have joined by phone now.
Okay, please, you have the floor. You can continue where Dr. Rusatira stopped.
Okay, I am not able to hear.
A few minutes to get your bearings. Please go ahead.
Okay. I assume that you can hear me, though I can't hear anyone else, but I'll continue the presentation. As Jean said, this slide is summarizing some of the data quality checks that we run with the data. There's often some hesitancy in using HMIS data. So in order to make sure that the analysis is robust, we look at two very specific elements. So the first is data completeness on the left-hand side. And we're showing here the completeness for outpatient consultations on the left-hand side of this image. And on the right-hand side is family planning. You can see that in most countries for outpatient consultations, the completeness or the number of facilities which report in a given month is quite high and quite steady. So above 75% for most months, and the month-to-month fluctuations are quite small. So we consider this to be relatively reliable data. And the big concern here is looking for completeness drops right after the pandemic period. Other indicators such as family planning, however, have very variable completeness. So it is a country by country decision on whether to include it and talk through the data quality. For outliers, we have an outlier algorithm that can go through on a facility level and look at outlier values. And here in this example from Cameroon, you can see some clear outlier values in outpatient consultations and polio, which were caught and removed from the analysis. So with these two data completeness checks, we're able to get very clean data. And by doing this facility level adjustments, we're able to unlock this HMIS data for further analysis. Next slide, please. So once the data are clean, the question then becomes, has the service volume changed since the beginning of the pandemic? And on this slide, you can see an example from Nigeria for, again, outpatient consultations, which we use as our general proxy indicator for overall health service utilization. The red line here demarcates March 2020, which is for us where we created the interrupted time series. And you can see right after this period, there's a drop in utilization. Next slide, please. On this data, we can then overlay our statistical model. And in this model, we take the trends in seasonality and trends over time and facility characteristics from before that pandemic period, so before that red line. And then we've used that information to forecast forward what the service volume would have been without the pandemic. And then you can see the service shortfall here is highlighted in that yellow area between those two lines. So when we use this forecast as our baseline service delivery that should have happened, and then we do this across the continuum of reproductive and maternal care, if we can go to the next slide, we can then see the final results from our HMIS analysis for the set of countries, where the 0% line demarcates the baseline of where we expected service volume to be, and then we can plot for each country the percent change month to month compared to that baseline. So here we have the 8 key indicators, starting with outpatient consultations and then going through the continuum of maternal, reproductive, and then the child patient services. These are our 8 key indicators in addition to other indicators that are local priorities. Next slide, please. So to do a quick review of the key findings here, one is that we find that all countries that we have analyzed experience drops in service volume in the first months of the pandemic. In some settings, these drops are minor, but in most settings, we've seen drops of greater than 10 to 15%, which we consider to be quite substantial. Next slide, please. The largest drops that we see across services are in the outpatient consultations and in child vaccinations. This is in line with what we know from qualitative research and just the changes in service delivery, especially in vaccinations, which largely stopped the large mass vaccination campaigns in those countries, at least until May of last year. Next slide, please. We do find that child vaccinations have returned to baseline and in some settings have rebounded to recover some of the shortfalls, but many countries had ongoing shortfalls in other services through the end of 2020. So this is an ongoing concern, especially as we see additional waves of COVID and slow vaccination rollout, that this question of essential health service continuity continues to be an ongoing concern. Next slide, please. And then as other presenters have pointed out, we don't see a clear pattern in the disruptions of these RM-initiated services. It seems like they are very context specific and influenced by the structure of the health sector and the different supply and demand factors that may be influencing these service utilization. Next slide. And then though you cannot see it on this graph, it is important to emphasize, as others have, that there is substantial subnational differences by both the geography and level of care. Most commonly, though not in all settings, we've seen that hospitals are the most disrupted and the clinics closest to the community are the least disrupted. And we see that urban settings are often more disrupted than rural areas, but that does not hold in all settings. Next slide, please. We also have conducted rapid facility assessments. I'll go through this relatively quickly since I know we're running short on time, but these assessments are a panel of the same facilities that are surveyed every month, and there's a set of modules. Next slide. Well, today I will focus in on some of the drivers of the service utilization. Next slide. Thank you. So to summarize the results from 3 countries with recent data, just to talk about some of the differences in some of these factors that may have caused the utilization. In Liberia, where we have results from between November 2020 and March 2021, we found that most facilities with volume decreases reported that fear of COVID as a major driver in November, but then by March of 2021, that dropped from 68% to 15%. In Liberia specifically, we also found that there was a severe lack of medical supplies that was a primary driver, which was cited by over 90% of facilities with decreases. In Nigeria, we found that the 2 primary drivers in September 2020 were fear of contracting COVID-19 and lockdown restrictions. But subsequent rounds through May of this year found no clear primary driver. And finally, in Malawi, we also find in this setting that the reported decreases are largely attributable to fear of catching and specifically getting diagnosed for COVID-19 during facility visits. And in our most recent round of work, we've also seen some suggestive evidence that fear of the vaccine is also driving more recent disruptions. In Malawi, facilities have also generally adapted by consolidating their care visits, supporting self-care interventions, prioritizing high-risk patients, and extending prescriptions of long-term use medicines. Next slide. To quickly summarize some of the limitations of this work, we need to mention that in some contexts, lower data completeness may be due to problems in reporting and processing of the data by strained health systems, which would bias the results somewhat. We also report that due to inconsistency in quality issues, we cannot rule out that other types of reporting issues that could affect results. And of course, our results only provide a partial picture, particularly in context with multiple service delivery pathways. Specifically for DHIS2 systems, we're not capturing that private sector and in some countries like community sector as well. And finally, the disruptions to service delivery could also be in the form of lower quality of care, which would not be detected in this type of analysis. Next slide. So our final conclusions and lessons learned from this work are, one, that there are clear disruptions to essential services in the first few months of the pandemic, but there are large variations in the pattern of disruption between countries and between different types of health services. It is critical to reinforce interventions for utilization gaps with innovative modifications, and the need for this type of innovation has not decreased, even though we're 1 year into the pandemic. This is especially true for health services in contexts which have not rebounded to account for previous losses. And we've seen in previous crises that delayed action can lead to higher incidence of disease and long-term health crises. And we also want to emphasize the point that this work that is presented today from multiple panelists shows that HMIS data is a very powerful monitoring tool, and investment should be made to increase the timeliness, coverage, and data quality to keep this data high quality and controlled by the country for future crises. Next slide. And then finally, if you would like some more information on the methods and other data, here's a recently published paper that you can reference. Thank you, and back to you.
Thank you. Thank you. Thank you very much, Dr. Ahmad and Rusatira. And sorry about the challenges with technology. We did request for some additional time since we started this session late due to disruptions to the connections. So we have about 15 minutes to discuss the questions that have been posted in the chat. And if there's any other question, please do post it so that we can discuss it, and then we will move to the wrap up. I see we have a question from Raj Kumar, and this is directed to Stephen Kawama. Why the little disruption in Democratic Republic of Congo? Is it because the performance was already low? Then we have a question here from Dr. Gerard Mutunji, a commissioner from the Ministry of Health in Uganda. And I think this is directed to the WHO team. Could the reduction in diarrheal diseases be due to improved hygiene based on some of the interventions directed at COVID? And then there is also a question to the WHO team again, why the improved performance in the second phase of your analysis. You mentioned that we have some good reasons behind this, and those might be lessons for some of the countries. Could you please highlight this? And then I hope the time will allow, but we would like to hear, even if it's just for 1 minute, from all the participants. We are now in a second wave or third wave, and for one country moving to the fourth wave in Africa. The trajectory for the pandemic is not good. What is the 1-2 issues that you would like these countries to focus on so that we don't repeat the mistakes that we made in the last response in terms of maintenance of essential health services? I know you all have recommendations, but just one takeaway that you think is the most critical, or a second one, if they can fit in 2 minutes. So rather in 1 minute. So we'll start with Stephen Kawama and then move on to the WHO team and then to the rest of the participants. Stephen.
Yes, thank you, Raj, for that question. So the differences in the extent of service delivery disruption might be attributed to the public health and social interventions that were implemented across the 4 countries. As you saw in our framework, we looked at both the public health and social measures, but also the health system measures. So we know for DRC, for example, they didn't have a national lockdown. They had lockdowns by provinces, and this might have led to their services not being disrupted as compared with the other countries. Of course, like the presenter from the Global Financing Facility mentioned, there are other contextual factors that need to be taken into account, issues of adherence, which may, impact on the way services are disrupted. Prof. Roda, you've asked us to mention, something to focus on as countries battle these waves of COVID-19. And I think the issue of coordination and taking deliberate efforts to ensure that services are maintained both at national level, but also at subnational level. So districts taking deliberate efforts to ensure that services are maintained. So monitoring the services, the indicators, and then taking actions to ensure that services are maintained. Thank you. Over to you, Prof.
Okay, we'll move to the WHO team. 2 questions there. The reduction in diarrhea, as well as the improved performance in the DRC in the second round. What's behind this?
Yeah, thank you. Thank you very much, Prof. Let me say one thing. When we look at the trends of indicators during this pandemic, I think one important factor is really the data quality issue. Completeness, data quality has been a huge hindrance in terms of interpreting these key indicators. The fluctuation and inconsistent trends of indicators is basically mainly related to the quality of data we're getting from HMIS in our countries. And having said that, it is very plausible to think the reduction in diarrhea cases could be due to improved hygiene and sanitation, especially the promotion of hand washing and use of sanitizer. This is the key thing in reducing diarrhea disease, but we need to substantiate that with evidence. The countries that have done surveys in coverage of hand washing and use of sanitizer has not supported that evidence. In many countries, the coverage is very low. So we need to look for the other side of the equation to make this attribution. Otherwise, it is a sensible way to think that if you have improved hand washing and sanitation, to see a reduction in diarrheal cases. With the performance of in the second round, I think the same thing. This is mainly to do with the data quality issues, and DRC. We know the health system issues, challenges, and so on, and also they have issues with data quality. We need to take that with a pinch of salt. Yeah, I think that is what I can say for now. Otherwise, thank you very much for those insightful questions. Thank you. Over to you. Back to you.
Thank you. Thank you very much. I can see clearly that the countries need to pay attention to the data so that we can do better with this data in terms of tracking what's happening to the indicators, and we are able to intervene in a timely manner. Let's hear from the World Bank team, and then we'll end with our colleague from Rwanda in terms of the key takeaways for countries, given that we are going through multiple waves across African countries. What are the 1-2 critical issues you'd like countries to pay attention to avoid the previous experiences in terms of service disruption?
Thank you. I think there's 2 lessons that we have seen so far in our work. One is that when you look at the disruptions, they occur largely in the first months of the pandemic. And in many settings and for many services, you don't see a strong correspondence and return of disruptions that correspond well to the COVID burden. What you see sometimes is a longer disruption that doesn't return to baseline, or it returns quickly. So what this might be telling us is that there's a level of adaptation and learning that's happening by the health systems, by individuals, by governments. And I think the work by exemplars and other groups is really showing, what those adaptations are. So then the question becomes, what were the key adaptations that we learned, and why, can we systematize those? What we've seen in some of the qualitative work is that, even during lockdowns where there were exceptions made for getting care at the health facility, if the public transport was closed or if the health workers couldn't get to the facilities, those disruptions persisted. I think the increase in PPE has also helped services return to normal. The second element that needs to be focused on is also this question about not just looking at this national level data, but also being assured that during these subsequent waves, we're also protecting those vulnerable populations and those vulnerable communities within those countries that might be masked by these aggregations of these numbers. So then the question to countries also becomes, what can we do to put in place safeties for these communities to make sure that they are also receiving the care? And I think in many settings, the answer to this could be task shifting to community health workers. I think that's a very strong and probably too often overlooked capacity of the health system that needs to be focused on for this question. Thank you.
Okay, thank you very much. A last comment from our colleague from Rwanda. Dr. Elemayu, are you on?
Yes, thank you so much, Professor Roda. Yeah, I think, this is a very interesting question. So one thing we learned from Rwanda is that most of the strategies, for example, that I mentioned, were developed prior to the COVID pandemic. So it's important that some of the health system need to invest on heavily on the system's inputs and quality, and then there should be a focus on coordination of activities, particularly between donors, implementing partners, to avoid duplication during the period of pandemic. So creating a health system that's resilient, nimble enough to current or future epidemic is a key to ensuring that we kind of mitigate the impact of the epidemic. Over to you, Prof.
Thank you very much, Dr. Elemayu. I see a hand from Dr. Teshome. Would you like to add to that?
Yes, Prof. Thank you very much really for this opportunity. I just want to emphasize on two things. One is really countries have to invest in data management. We have seen the power of data in decision-making, in programming, but we have a huge issues with data quality and completeness. And COVID has taught us a big lesson to really invest in the health information system. That is one message. The second message is initially there was unbalanced approach in terms of the COVID response, basically focusing on the COVID response and neglecting continuity of essential services. But I'm happy to report that most countries have now appreciated the importance of maintaining continuity of essential services and have included in the emergency preparedness and response plan. But still, there is a need to work very closely with the program people in terms of actualizing the implementation of the integrated plan in order to ensure continuity of essential services. If you can just give 1 minute, if Korabacho has anything to add, I would be very happy, Prof. Thank you very much. Over to you.
Sure. Let's hear from Korabacho, please. 1 minute.
Not much really, but thank you again for the opportunity, Prof. And Teshome. I would like to emphasize on the issue of data again, because we have seen how much it is important during such pandemics, but also before the era of the pandemic. The issue is, again, we need to be very cautious when we talk about data quality, because data quality embraces a wide array of dimensions. So probably one of the issues that was missed here is the capacity of countries in using, not just collecting, but using the data for decision making, starting from analyzing and then statistical comparison and issues like that. So it might not be the appropriate terminology here, but I would like to emphasize that the countries also need really a very big support in terms of bringing them up to the level of, collecting and then using the data that they have at hand at different levels. Most of the focus across organizations has been input at the national level, but I think going forward, as COVID is challenging us in different ways, we also need to think about subnational level comparison of services, and that needs, again, capacity building of government institutions, particularly at the subnational level. Thank you very much.
Thank you very much for your contribution to that. If we don't use our data, then we will not even know the quality and we cannot improve it. And yet we need it to track what's happening. So that's really important. I'll just do a quick summary of some key messages. I can see some people have just joined us now as we are wrapping up. From these really rich research studies across various countries in Africa, we see various levels of disruption to multiple indicators of utilization of essential services across the countries. We can see, I was very concerned, the biggest disruption to vaccination for children. This can actually potentially cause other epidemics, so we need to pay attention to this. And it's good that we see a recovery of these indicators for vaccination across the countries, in addition to the others, maternal health and other indicators. On the other hand, the recovery to the pre-pandemic levels for these indicators could mask vulnerable populations, so we should not be comforted, and we need to do more work to see that we are not leaving some populations behind. I would also like to add that also just returning to 2019 is not good enough for us, because many of these indicators are not good enough. We are driving towards the SDG targets to improve the health of our population. So we can't just be satisfied to go back to 2 years back. We need to do much better. We need to not only recover, but we need to catch up and go even higher if we are going to meet these targets and protect our populations. And then all the speakers have talked about our health systems. We need resilient health systems. We've heard that from all the speakers. This means that as we respond to pandemics, we need to do well as well in terms of maintaining other essential health services so that we are not disrupting them and we are not causing morbidity and mortality due to these other conditions. We need a balanced response that can bring down the COVID epidemic while also continuing to provide essential health services. And we've talked about some of the underlying issues here: mobility for health workers, mobility for people who are sick so that they can attend services. But also we see the fear of COVID, the fear of catching COVID. It's among health workers. We need PPEs. We need to vaccinate as many as are willing to. And we need to roll out the vaccination perhaps so that we can give more confidence to the communities as well. And they don't fear to come. As well as also providing them support to be able to observe other protection measures against COVID. Data is the issue that we have all emphasized. We need data so that we know where we are with these indicators. We know which indicators have challenges, whether it's at national or subnational levels, and we are able to quickly intervene. Thank you so much, all the presenters from the World Bank, from the World Health Organization, from the University of Global Health Equity, from MNCAAH University School of Public Health. Thank you, my co-chair, Professor Fowley, for supporting this session. And thank you to you, all participants, for your excellent questions. And those who are following us on television, I'm informed that this session has been on television. Thank you so much for listening in. And thank you so much, exemplars in global health, for supporting us to co-host this session and also for supporting this research. I hope that the lessons that we've picked from this session can improve our response for the current upsurge of cases in Africa so that we can maintain essential health services even as we respond to COVID. I hope you will also continue to watch other sessions in the World Health Summit, and please enjoy yourselves as you go around to see, connect to your next session. Have a nice day, all of you. Thank you.